Jay. Really excited to be here. Second time, or actually third time speaking at the SACS Forum. It's fascinating, something that Leonard has been starting and promoting to keep bringing more investment as academia, as I'm delighted to be representing academia here together. So I'm going to kick off the panel of personalized approaches, precision and combination therapy together. And I'm going to start with a little bit of a 15-minute introduction of what we have been doing at Mayo and how we see the future of obesity and cardiometabolic diseases. I'm going to start with some very traditional academic concepts of just saying who we've been working with. I want to highlight two companies, Gilead Therapeutics and Phenomic Sciences. I'm going to be talking about Phenomic Sciences work, as that's who we license the technology to start commercializing the first test to predict response to GLP-1s, but also to show in this slide that we've been working with pretty much everyone in the cardiometabolic space and receiving funding from them. So thank you all for your support. So as we are digesting our food, I want you to bring you back to my clinic that I was here on Wednesday, and I'll be next week in my clinic, and tell you about my patient. When I'm going to see my patient, I know absolutely nothing about my patient. I might know their BMI because that might be on their chart. So I might say this patient has a BMI of 40, but I don't know anything else. And then we stop here for a second and we just think about oncology. If my colleagues in oncology are going to see the patient, by the time they're going to walk into that room, they're going to know, for example, in breast cancer, the size of the mass in which of the two breasts is, whether they're lymph nodes, whether they're mets. They're going to know the biology of the tumor because it was already biopsy before the oncology walk in. And then by knowing the biology of the tumor, you'll know whether they're expressing receptors, what is the transcriptomic of the tumor, how aggressive it is, what's the level of inflammation in the tumor, risk of recurrency of treatment, and then they walk into the room. They have mapped out the biology of cancer. In cardiometabolic diseases, we're probably, I want to say, some days I say 2 decades behind, some other days I say 4 decades behind. We need to move towards that future that we are seeing in precision oncology. We need to move it towards in obesity. So what is the biology of obesity? And we've been seeing a lot of that from our colleagues in Novo Nordisk who are saying to our patients, it's not your fault, it's your biology. I say the same thing to my patients. It's your biology. But what is in the biology? What's the biology of obesity and why this matters? It matters because right now, in the space of obesity, we have multiple challenges. We have heard about many of them this morning. To me, one of the most important ones as a physician is this one. I don't know, let's see if the laser works. Nope, points here, no. I don't know who are my patients who respond to semaglutide. Here are the data of semaglutide treated in the clinic. These patients paid $11,000 that year. These patients paid $11,000 that year. Some of them did amazing, some of them did not respond. I don't know who my patients are going to be who lose that weight. Everybody pays the high cost, and we have limited access to these medications. So how do we address the problem of cost and limited access? We try to address the problem of the heterogeneity of response. This heterogeneity response is not just to semaglutide or GLP-1s. We have seen in our lifestyle interventions, endoscopic procedures, surgery, and all anti-obesity medications. And whatever you guys are going to develop, unless we do it in a very targeted fashion with some sort of diagnostic criteria, you're going to see the same heterogeneity response. So how do we address that issue when we talk about precision obesity? First, there's already some concepts of precision medicine in obesity. We know that in the case of when there's an abnormal genetic mutation, we know that we have drugs that can target that and we have very great outcomes. That is the best example. When patients come with leptin deficiency, if we give them metroleptin, they completely lose their weight, their disease gets resolved, and these kids go on with life. Similar examples we have seen with mutations in the POMC, PCSK1, LEPT-R mutations, Bardet-Biedl syndrome, and Alström syndrome. We can give them a melanocortin-4 receptor agonist called setmelanotide, and we have seen impressive outcomes as shown by Peter Connon in this study in the New England, in which you not only treat the hyperphagia, but you also resolve the weight loss. So this concept of precision obesity already exists, but this is for rare genetic disorders. Less than 0.03% of the population has them, so very rare. How do we address the problem of precision obesity when we think about the common obesity? We need to take a different approach in which we do a real obesity stratification. And obesity is very complex. So when I say what are the phenotypes of obesity, If we have 10 academicians, we'll come with 10 different types of phenotypes. So the thing is that we need to think about the complexity of obesity one more time at the patient level. And what is at the patient level? We right now call obesity and define it by BMI. That's the severity of obesity. And we all have agreed, and we already heard this morning, that's not the right term. That's not the right thing. We need to move beyond BMI. How do we move beyond BMI? We need to move towards an obesity that we talk about 4 status or 4 domains of obesity. We heard about metabolic as one of the status, glucose regulation, metabolic domain. We heard about the fibroinflammatory domain. We've been hearing about the hedonic reward domain, and we need to think about the energy balance domains. These 4 domains tell us who we are. Now, as humans, we might have those domains, and it's okay if I want to have dessert after the meal. That might drive to my obesity, might not drive to obesity. It just might be a trait. But these domains matter, and they all interact with each other. If I have hyperinsulinemia, that might drive me to increase my appetite. So they're coming together. More insulin, more inflammation. So we know they come together, but they're not independent. I also can see people with have high insulin resistance without inflammation. So we need to think about these domains. Then we need to separate them from the obesity-related comorbidities. We need to bring this to social determinants of health. And then we need the omics, because that's the state of the art of the science in which genetics, exposomics, epigenetics, metabolomics, microbiome, and proteomics all need together. So I hope that within the next decade, or by year 2031, and we're talking to today, what will predict the future, we can advance towards diagnosing these things in our patients. Not just things that we know do in the labs and the academics and you guys do in your R&D programs, but really bring it to the patient. So next time I want to manage someone's inflammation, there is a measurement that I can do that is reliable and repeatable that I can measure in the clinic. So I'm going to show you now in the last 5 minutes, I'm going to go through our examples of energy balance and what we have been doing in this space. How do we do it in the academic world? Well, we measure energy balance, and we measure with objective tests. We measure energy expenditure, we measure body composition, we do gastric emptying, solids and liquids to measure visual scales, we do questionnaires, then we do an ad libitum meal to see how many calories someone consumes, and we continue doing visual scales. All these things I did not invent it. We've been doing this for 40 years. What we did invent it is we said, well, what if we look at patients different ways? And we did a subclassification using unsupervised machine learning, and we came up with these 4 types of obesity. People who have abnormal calories to satiation, I call this the hungry brain phenotype. People with abnormal postprandial satiety, I call this the hungry gut phenotype. People with emotional hunger, and then finally people with a slow burn or abnormal energy expenditure. Some people call this sarcopenic obesity. So these 4 types of obesity explain about 85% of the variability with obesity. So now let's dive into a couple of them right now. Abnormal satiation, call this hungry brain. Abnormal satiation is a simple concept in which we start eating. We all went to eat right now, or I hope we all did. We start eating and then we eventually stop. When you stop and you reach your calories to satiation is when you say, I'm feeling full. How does this happen? We start eating, the stomach gets distended, those signals get through the vagal nerve to our brain, and our brain tells us it's time to stop, and CCK plays a role here important as well. So when we look at patients with this concept, and we look at patients in their brain, and we look at their hypothalamus, if we look at different individuals based on their obesity versus lean, and we look at baseline, when they reach their VTF or volume to usual fullness, maximum tolerable volume, or maximum tolerable plus 30 minutes, there is no difference. But now when we separate our patients based on those who have the high calorie association versus those with the phenotype versus those, now we can see that these individuals in their brain, in functional MRI studies, have abnormal blood flow in their brain. So now we can find them. I can do a functional MRI study and find them, and some of us do functional or do MRI elastography for liver. We can find people. Now we can find this. But of course, doing MRI is complicated, particularly functional MRI. So we decided to look at their genetics. What we found in their genetics is that, well, there's not one gene that drives you to eat more calories. If we take 41 genes and we do a gene risk score, a polygenic risk score, we can see that the higher number of genes you have or abnormal copies, the more calories you consume. Tells you that what we're eating until we feel full might be driven by our genetics. And of course, in the era of machine learning, we took this concept and we built a model to predict outcomes using machine learning. And then in our model, we can predict who will consume high calories based on their genetics with the training cohort of 0.85 and the validation cohort of 0.82. So very exciting. Calories to satiation matter. We can see it under an MRI. we can also get a genetic machine learning assisted test. So why this matters? Why I've been showing you this data? Because now let me show you what it matters in the clinic to my patients. So here's a trial that we published last year, phentermine topiramate extended release, first generation medication. Two medications that are very well known to us who have been doing obesity for more than 15 years. In all comers, this medication gives you 14%, placebo gave you 4%. When we measure their calories to satiation, those with a high calories to satiation, people lose 16.5%. When we do the genetic test for calories to satiation, or this genetic biomarker, patients lost 17.7%, and if you do not have the genetic test, you lost 10.8%. So now we can show you that a biological trait that we all humans have, and a surrogate biomarker driven by genetics, can give you better outcomes with a medication that is extremely cost-effective, affordable, cost-effective. Now, what happens when we use the same genetic test and the same trait for GLP-1s? Here's a study, also randomized placebo-controlled trial with liraglutide, 16 weeks, 5.7 at 16 weeks, very expected trials. When we look at the biological trait, now the high calorie satiation predicted the poor responders, not the no responders, the poor responders to liraglutide, while those without the trait lost 6.1%. And then when we look at the genetic biomarker, similar thing, 3.3% versus 6.4%. So now we can use genetics, not only to find who will be the best responder for phentermine topiramate, but who might be the poor responders to GLP-1s. And then because, of course, you all want to know about semaglutide and tirzepatide, here's the data with sema, 84 patients, and we can see that those with the trait, the high calories association, they are actually the ones who have the poor responders, losing only 10% at 1 year compared to patients with 19%, which is very exciting that we can find this. Now, in the last few minutes, I'm going to switch the story to another concept. So I told you about satiation. Now I'm going to tell you about postprandial satiety. Two different terms, two different terminology. So postprandial satiety is a little bit of a different phenomenon. Many people put them on the same bucket. It's like, oh, it's all the gut signals going to the brain. But satiety is different by a different phenomenon, a phenomenon of gastric emptying, releasing the food from the stomach into the small bowel, releasing hormones like GLP-1, PYY, CCK, leptin plays a role to slow down our gut, tell our brain, hey, give me time to digest. We measure this with visual scales and gastric emptying, nothing new here. And we have shown that gastric emptying correlates very nicely, as you can see when the gastric emptying starts coming down on the black curve, with the red curve of hunger. So now the question we were asking ourselves is what's happening with GLP-1 when we were looking at postprandial satiety? And we know that if you empty your stomach faster, you feel more hungry. So gastric emptying and hunger goes hand by hand. So we say, well, GLP-1 should matter. If I empty the food from the stomach, that food should go to the small bowel and release GLP-1. And we were expecting an inverse correlation like this between GLP-1 and gastric emptying, and gastric emptying. And we actually saw a very weak correlation between GLP-1 and gastric emptying. So we decided to apply similar machine learning methods in subclassifying the population, particularly to look at these patients who have the abnormal phenotype. And what we found, and I'm going to go quick through this just to explain the concept, is that we are expecting to have a normal gastric emptying with a high release of GLP-1. If we have a rapid gastric emptying here, we actually saw what we were expecting, a high release of GLP-1, but then we saw a cohort of people that have a rapid gastric emptying with a lower level of GLP-1. These patients here are GLP-1 deficient, or what we call discordant gastric emptying GLP-1. What it was fascinating to see is that when we take these patients and we do colonic biopsies of their enteroendocrine cells, they're not producing enough enteroendocrine cells of GLP-1 and PYY. So these enteroendocrine cells are not making enough GLP-1 and PYY. They have GLP-1 and PYY deficiency or enteroendocrine cell dysfunction. Again, why am I boring you with all this data from human data? Is because when we look at these patients treated with tirzepatide, those who have the enteroendocrine cell dysfunction lost 22% in 6 weeks. This data is better than retatrutide. So finding the patients who are enteroendocrine cell deficient are the super responders to tirzepatide. Not a lot of patients. Of course, it's an academic study. It's not a big pharma study. But you can see how these individuals, all of them are super responders. So going back to my patient, I hope that now we can think about energy balance phenotypes. We have actually take all this technology and spin it out into a company that Mayo Clinic led with a couple of other investors, the AMA, LabCorp, United, and Dexcom. And now we have my phenome test available. We think the future of obesity is precision obesity. And we have outlined in multiple publications how we think we need to manage based on phenotypes in order to turn these obstacles into opportunities, have less heterogeneous outcomes, more targeted therapy. Obesity can be cost-effective, increase access. And of course, this is just the beginning. And just for you guys to think that I'm not thinking only about appetite regulation, I think obesity today can turn into a diagnostic scape panel in which we should measure insulin, HOMA-IR, FIB4, CRP, FibroScan, measure hedonic questionnaires, and measure this panel for the energy balance regulation, as well as measure fat mass with DEXA. So I'll be delighted to take your questions, and I think this is the future of obesity. I'd love to hear your thoughts and reactions, and looking forward for the panel. Thanks again for the invitation. We'll do some questions.
Yeah, take some questions for a few minutes. Yeah.
So we'll take some questions here if there's any questions or reactions before we start the panel.
Do you think Pharma wants to know?
Depending on which pharma. You know, I think when we are in these Russian competitions for maximal weight loss, eventually someone will say, I think I can deliver that in a subpopulation, maybe 30, 40%, but give you better weight than anyone else. I will also think that pharma will also know who are the patients who do not have side effects. And what I think at the long term, I hope that everyone in pharma will realize is that the current model of a lot of patients starting the medications and dropping off will not have that chronic care that we see on lipids in hypertension and diabetes. And a way to change the conversation and get patients to use the medications for more than 6 months on average is to change the conversation and tell them, you know, I'm going to give you this medication because you are enteroendocrine cell deficient, or you have a hungry brain and you have this genetic biomarker. And that way patients will never ask again for how long I'm taking this medication. They will know they'll take it for life.
Thank you, Professor, for your insight. Particularly, I'm impressed with your presentation on the heterogeneity and complexity of obesity. It appears that so far, pharma has focused like a silo approach to reduce weight loss, right? To get weight loss, and we encounter a lot of obstacles like muscle, loss, as we discussed this morning. Do you think that to able to overcome or bring to next level the next 7 years, the therapeutic for obesity have to include all the factors like inflammation, all the factors that you look at the omics here? Yeah. Can you highlight the future approach for obesity therapeutics the next few years?
Yeah, I think if we go back to this slide, show my slide. But if I think we go to my last slide in which we make the diagnostic tests and we really find a way to treat and diagnose each one of them, we will go beyond weight loss. Because we have a lot of patients who might have a normal weight, but their percentage of fat mass is high. So despite having, let's say, a BMI of 25, they have 35% of body fat with impaired fasting insulin, with elevated CRP, with maybe already some markers for fibrosis. That has nothing to do with weight. So we need to move beyond weight, but we need to move beyond weight not towards obesity comorbidities. Because when we say let's move beyond weight and weight loss to just treat MASLD or obstructive sleep apnea, that's fine. But we need to treat those diseases. But we also need to move beyond weight loss and treat the underlying biological underpinnings that are really driving the disease. So we start preventing the disease, we start really managing these conditions so we avoid the long-term consequences of obesity and cardiometabolic diseases. All right, super. Well, thank you.
I have a question for you, actually, too. One is, in the 4 segments, that hungry brain and so on, is there overlap? Do some patients fall into both? Or is it mostly a correlation of one or the other?
No, there is. So about 27% of patients have 2 or more phenotypes. And the way that we do manage this on the clinic, as well as on the report from my phenome, is we tell you what's the most predominant phenotype. And then we allow physicians to do what physicians do best, the state of the art of medicine, in which we say, well, if you have, for example, you have hungry gut, or you have this, you likely are going to respond better to a GLP-1, and we know those are better medications. I might put you on that GLP-1 first, and maybe introduce a diet for your other phenotype. Or do a combination of, for emotional eating, refer you to a psychologist for a psychologist program, where I'll use the medications for the other phenotypes. So, but yeah, they do happen.
Yeah, and then the other question I have, and you may have an early glimpse into this from statistics, is are there comorbidities that will lean more into one of the phenotypes than another? So you might have one with more sugar dysfunction or that kind of thing.
Yeah, so far we have not been able to find anything. And the phenotypes don't predict your BMI. Yeah. The phenotypes so far have not been able to predict which comorbidity is associated with. And we have looked now at this in about 98,000 patients. So we don't think the phenotypes, I think the phenotypes are telling us you're more predisposed to weight gain. And once you gain weight, you're going to have the same comorbidities associated with it. So they're not really driven by comorbidities.
All right, so my name's John Westwood. I'm from a company called Lumanity, and I'm basically a life science strategy consultant. I've worked for 30 years on enterprise and product strategy in leading consulting firms across the world. And I'm very pleased to be here to do this panel today. I'm going to ask the panelists to introduce themselves and just give a few words about sort of why you're in the space and why you're here today.
Hi, I'm Marija Mavar. I'm president of Pharma Solutions at Perspectum. So Perspectum is a quantitative imaging company that supports sponsors with biomarkers in clinical trials. We have extensive experience in MASH, in cardiometabolic disease, and one of the programs, for example, that we work with is a survodutide program. So my perspective here is really kind of from that, being involved in a large number of trials, we see how the field is moving from just looking at weight loss alone to actual biomarkers of disease, multi-organ disease, of different tissues, etc. So kind of shifting to that, where is the weight being lost? So body composition, but also how is that impacting multiple organs?
Hi, I'm Lloyd Diamond, the CEO of Nitinotes. We've developed, not a drug, but a minimally invasive procedure for stomach restriction. So think of surgery, but incisionless through the esophagus into the stomach, and then our device sutures the stomach, creating a sleeve, essentially, where the patient will reach early satiety and slow gastric emptying, getting to your presentation. And I myself have about 30 years of experience in disruptive medical device and drug device combination therapies, half of my time in Silicon Valley and the other half in Europe. So I've been able to work on both sides of the Atlantic, and happy to be here, to be the device voice in the drug landscape. So.
Great. Laurent?
Great. Yeah, delighted to be here. Thanks, everyone, for spending some time with us. So my name is Laurent Audoly, and I'm the founder and CEO of a precision medicine company in the obesity-associated disease space. More precisely, we are focused on addressing the root cause of end organ damage and metabolic dysfunction. And when I hear Andres' presentation, and we've met in the past, you know, we're sort of speaking off the same sheet, just coming from slightly different perspectives, with the recognition that there's a huge opportunity here to propel this whole space of heart, kidney treatments into the present time. Part of my background is building companies from scratch, and I've done a couple of companies in oncology prior to building PriveBio. And coming out of oncology, you don't even say precision oncology anymore, right? You just say oncology, and you sort of take it for granted. This imaging, multi-omics type of phenotyping, molecular endotyping. So I think there is a fit-for-purpose approach in what we're going to be talking about. In other words, we're not suggesting at PriveBio that you need to come in with, you know, a full genome being sequenced and a whole set of images, but there is certainly some opportunities here to adopt a more thoughtful phenotyping, more molecular-based type approach. So anyways, we'll talk a little bit more about this. My background, I've basically been discovering, developing medicines like many of you. Started off in big pharma across cardiology, inflammation, immunology, and then 10 years ago sort of switched gears towards company creation and scaling companies.
Great, thank you. Do you say anything?
No,
All right,
let's get
introduced
started.
you twice.
Yeah.
All right, so please do think of your questions and ask the questions. We'll be doing questions at the end, but if you have a burning question, do stick your hand up. One thing I don't like is a quiet room. So I'm just going to open up for the panelists just generally. I mean, what would you consider to be the state of precision medicine, I will call it that, in the cardiometabolic and obesity world right now? And maybe Andre, we can start with you on that one.
Yeah, I think infancy will be too generous. We're really starting here, so I think it's a great opportunity to really think about, you know, what are the actionable traits, actionable biomarkers that we can actually move towards the clinic and help us care for our patients, deliver better outcomes, and, you know, bring health back to them.
What about any of the other? What about you, Marija? Do you have a view on it?
Yeah, I think we're getting started and we're making some good progress. I don't think we're in the, I think this presentation was lovely. It was very encouraging, but I think we're still at the point where the best we can do with precision medicine in obesity at this point is select the right patient for treatment, not yet select the right patient at the right time with the disease for the right treatment. Mm-hmm. But that's already quite good. So I think we can work on that and just making sure that the patients that we're selecting for treatment are the ones that need it most.
Yeah. Laurent, do you have thoughts on it?
Yeah, so let me just take a half step back. So I'm going to talk about two frameworks and just focus on one of them. I mean, obviously, you know, the quote-unquote holy grail, at least from our end, is prevention, right? Is to catch people before the disease is irreversible, right? So that's one part of what we do at PriveBio. But it's always with the idea of also better understanding the diseases that we focus on. So from our perspective, there's a huge opportunity for better phenotyping diseases that we believe represent, like I mentioned this morning, you know, staggering unmet medical need. You know, we've talked a little bit about heart failure with preserved ejection fraction. And again, going back, unfortunately, to the cancer setting, I mean, 80% mortality at 5 years, right? That's not acceptable in this day and age. And that's just one example. And so it starts, though, with a better understanding of the disease by phenotyping it, as Andres was saying, by doing some molecular endotyping, and just by putting it all together. And that's just one example. So the conversation, to be very transparent with you, we're having, this is a great group. We probably overrepresent the people that adopt a precision medicine framework. And our job is twofold. One is that, you know, we are constantly building that awareness of precision medicine, the need today, and also telling them how great of a pipeline, you know, we've built and that it's fit for purpose and now's the time. And my last comment there is that my sense, but I'd love to hear everyone's perspective on this, is that we're just coming out of the incretin sort of rising tide. And I think one of our challenges is just to tell the world is like, look, these are amazing medicines, we know, but there is a significant amount of residual unmet medical need here, and we need to talk about that too. So it's not just weight loss, but it's also post-weight loss. What else is happening? Because we see there are lots of problems everywhere on that post-GLP-1 world.
Yeah, sorry, maybe just a perspective, I'll rebound on what you say. I hear the word disease a lot, and we had this discussion on our prep. You know, I spent many years in the orthopedic world. And those diseases are easy to diagnose. You can see them, there's x-rays, there's ultrasound. And for many years, we've talked about precision medicine and orthopedics, right? You need a specific implant, you can 3D model things, and you can diagnose it, and you can find something to repair it. I'm not even sure that in the world of obesity, we've all agreed what constitutes the disease, and has the world admitted that obesity is a disease? And then you have, I think, the greater complexity that some people, they overeat because they can't control themselves, and other people, it might really be a disease in and of itself. So before we talk about precision medicine, I think there needs to be agreement about whether or not the world looks at this as a disease. I mean, the World Health Organization labeled it such, but there's still a big stigma around obesity. So maybe we're jumping the gun a bit. Anyway, that's my perspective on it.
Yeah, maybe also a comment to where we actually are at the moment. So we do have basically 2 GLP-1 drugs and a GIP-GLP-1 drug on the market currently. So that is, at the end, it's incretins. And if you look at the reality, we diagnose by BMI and we treat by percent or kilogram weight loss. This is actually not what we wanted to diagnose, because at the end we want to treat excess adipose tissue, right? And not BMI or kilogram. So we don't even diagnose what we want to treat, and we don't monitor what we want to treat in the first place. And even like a simple question as to why we see this major difference between people with obesity and those with diabetes being treated, where we have about a 5% difference, lower efficacy in those with type 2 diabetes. We don't even understand that simple equation in the population that we investigated and where the products are on the market already. So that leaves me basically with a question, when you think of, and that was on the slides also, in terms of precision from Andreas Acosta, is when you think about its incretins, right? So they control usually glucose, they control insulin, and gastric motility, then you wonder why is it that we have that treatment difference of 5% between diabetics and non-diabetics in the first place. So I think we should, first of all, or we need to understand the fundamentals actually first, and then ask, okay, what are the next steps to be taken?
Yeah, everything, Robert, I think you raise a very important issue, which we need to understand not only obesity in itself, how on each of the comorbidities we have different outcomes. And while it might take also decades to understand the mechanism of why things changes, I think the first thing we need to do is start setting up the right expectations to each one of our patients and our physicians. Because right now when a patient comes and sees me, Doc, I just saw an ad last night that, with this drug I can lose 46 pounds. And you see the patient is like a 60-year-old gentleman with a BMI of 45 with 10-year history of diabetes. I'm like, sorry, you're not going to lose 46 pounds, right? You'll be happy if you lose 20 with the same medication. So if we don't set up the right expectations and we start talking with a little more, truth to ourselves of, what is the real truth to each one of our patients and expectations, I think that's where we need to start. So just please set up the right expectations to each of the patients. But then I completely agree with you. Once we start understanding the mechanism of why people in the SELECT trial lose less weight, people in all the MASH trials lose less weight, people in diabetes lose less weight. So what is within those populations with more advanced disease, as Laurent was saying, that they might have more an irreversible damage, and I love the term, it's too far. What do we need to understand? What do we need to do different? So then is when maybe a GLP-1 might not be enough. Maybe we need a medication to tackle fibrosis and inflammation and what else is there? Maybe an insulin sensitizer or something else for insulin resistance. So that is what I think by characterizing better the disease, we will get better long-term outcomes and we will change the conversation, right? So we need to mature our thinking process as we've done in cancer.
Now, there are several ways of thinking about that, right? And there are barriers there as well. Educating people, changing ways of thinking. And I've got a sort of big pharma question, which I'm probably going to send over to you, Robert, which is How's Big Pharma thinking about, and you may or may not know, the stratification of patients, right? Because you look at big markets, there are lots of classes now coming in that are GLP-1 and plus and adjacent and all the rest of it. Are there talks about deals or using biomarkers or imaging that could start to give more information? Do you have any perspectives on it that you can talk about?
I would say at the moment it's mainly about differentiation in the first place that defines what is maybe then the clinical study to be conducted. I would say it's not a priori sort of situation where at least I do see that there is a specific use of biomarkers to better understand the patient, but it's more about how do you differentiate about what's already out there and how you better address the unmet need. So at the moment, I would say it's mainly driven by the differentiation that goes maybe towards benefits beyond just losing weight or excess adipose. It's going towards maybe the comorbidities at the moment. One thing, maybe if I may, just to add, one thing I'm missing a little bit, unfortunately, in the obesity discussion, and I think that's why I'm grateful that we have that discussion now, because we need that, is like when you look at blood pressure or LDL cholesterol or even atrial fibrillation, we do have preventive care, right? And somehow this discussion seems not to happen yet, but I think it has to happen also in obesity. What is the actual treatment goal?
So there are bottlenecks here, and it's actually interesting in the early evolution of like new diagnostics, like we saw in oncology, back in the past. The business model of the innovator is often to work with pharma in clinical trials, right, to help with stratification, and sometimes the gentleman in the white jacket, he left, but said, do they want it earlier, which I think is one of the things. Do any of the other panelists have perspectives on that? Because we're at the beginning here, so Laurent, you might.
Yeah, John, and maybe tying this back to what Robert was also mentioning. So, data is king, right? So biomarkers can be interesting, but are they actionable? And so our approach is that we go after the biomarkers that we believe are disease drivers, and we're going to target them, and we're going to show that we neutralize or modulate the target, and then we'll measure a little bit more downstream. What does that biology mean? So might do a adipose tissue biopsy, and then we'll go even further downstream, right? We talked a little bit about different tissues, but my little plug here would be that if we wanted to start to nudge the discussion towards more of a precision conversation, I think, and we're starting to see it more, but I think we need to do a lot more. We need to talk about visceral adiposity versus subcutaneous adipose tissue, for example, right? So now we're starting to talk about, perhaps the incubator of a lot of the bad things that are then secreted in the blood and across tissues that are perhaps driving some of these end organ damages and metabolic dysfunction, right? So I think biomarkers, absolutely, we should biomarker a lot, but we should always be asking ourselves, how quickly am I going to be able to show that if I modulate that biomarker, that actually translates into biology and ultimately outcomes? Because, at the end of the day, I think, for what it's worth, it's all about outcomes, right? That's what the precision framework needs to do, right? Is we need to much faster show improvement on outcomes, reduction of death, right? Improvements of survival. And if it means that it's hinging on a biomarker to stratify a patient, get them into a trial and show that that patient actually does better, I'm all for it, right? But if we don't have that, I think we got to be careful. I think, like Robert, I think you're getting at, which is biomarkers are good, but not great unless they're actionable.
I'm going to build into that, Laurent, because I always like and enjoy listening to you, and what you guys are doing is fantastic. So one of the things I keep telling myself which genetics is great to tell us, who we are, but it only tells us so far. And I want to build on what you just said. I think for us and for everyone working on the field, we're trying to now build what it will be a monitoring biomarker. And let's think about this, because if I come and take tirzepatide and I lose more than 20% of weight loss, that could be great. But what if that weight loss and that pathway is not fully tapped, and I still don't have full metabolic improvement, meaning I still have room for improvement on diabetes or sleep apnea or things like that. Let's just think about comorbidities. How do I know whether I add more tirzepatide, I switch it to Reta, or I need to add another agent? Maybe, a Survo has a more glucagon component, right? Or I need to add completely something different, like an amylin. So how are we going to help physicians make that decision? And when we have 10 different types of meds, maybe the majority of them will be GLP-1 based, but different combinations. What is the next step? How do we make that decision on practice when we have not fully tapped the parts, or the patients start regaining weight or plateau early? So we need to understand and map up the journey of the patient. And that needs to be also beyond just simple weight. I love when my patients come and tell me, Doc, the drug's not working anymore. I stopped losing weight. Did they work? We know they work. The drug is working because they're not eating what they were eating before. Their fullness is completely tapped. Their postprandial satiety is tapped. But how do we know what's the next step? And I think that for that we need biomarkers that we can monitor through time. Like, not too far from our field, hemoglobin A1C. Hemoglobin A1C changed the field of diabetes. Diabetes was managed by a few endocrinologists, some of these in this room, right? Measuring fasting glucose and postprandial glucose and all these complicated things. Once hemoglobin A1C came to the market, diabetes is now a disease of primary care. Everyone feels comfortable with managing diabetes and monitoring. That's what we need, Laurent.
I mean, the news is right. Every day there are more and more patients falling into that type of category. Yep. That it's kind of they're not stuck there, but they're at that plateau, and then these bigger decisions need to be made, right, to keep them, remaining as healthy as possible. And Marija, I haven't forgotten that you're over there. So, what are some of the barriers, do you think, to what we're talking about to actually get this adopted? If we think about, is it payers, is it sponsor willingness to have these things put in clinical trials? Is it knowing what biomarkers we should even be looking at, or even just clinician workflow, right? I mean, what are some of the barriers you might see?
Yeah, so for imaging specifically, from my experience, sponsors are quite open to using imaging in clinical trials. They understand that these are where there's evidence, these are surrogates of clinical outcomes ultimately. And so they're willing to include them as for patient stratification, for enrollment or enrichment, for monitoring, all of that. So I think that's not the barrier. The barrier comes from when that needs to translate into everyday clinical practice. And there's a number of reasons. So probably the bottleneck somewhere at the intersection of clinical adoption, payer coverage, availability, all of that. So there's really a long journey from establishing evidence, having a very validated biomarker, and then integrating that fully into clinical practice. There's a lot of steps that need to be done. So, yeah, that's my view.
And how do we overcome those barriers? What are some of the ways we can do it, do you think?
So, I mean, there's a lot of market access activities, a lot of physician education. There's a lot of activities. I mean, from our experience and experience of other companies, kind of similar precision medicine, AI-backed software as a service companies, we know that reimbursement needs to be somewhere around 70+% of the population for the US in order to actually make that difference and encourage clinicians to actually rely on a biomarker because they know that the patient will have it covered by insurance. Mm-hmm. So yes, there's a lot of strategies that one needs to do.
I'm going to repeat something I said last night on dinner. I always give kudos to Novo for really building the GLP-1 space because they have, and then Lilly has followed and made an amazing job. But if we really think what Novo did is Novo put the word Ozempic on the map, right? GLP-1s were invented 20 years ago, right? So it's not like GLP-1s were new. But suddenly everyone started talking about Ozempic. I think if we want to change the space of precision obesity and bring diagnostic tests, whatever they are, imaging or molecular diagnostic biomarkers, I think we're going to need large diagnostic companies to come into the space. So if any of you know any of them, please call them to jump into the space, because GLP-1s are the biggest drugs in our history of medicine. And it's the first time that there is such an amazing boom in blockbuster drugs, and there's not a diagnostic pair that comes with it. So they're missing this big opportunity, and they just need to help people like PriveBio and our startup and many other startups who are trying to see how we bring precision obesity into the space.
So we're talking a lot about therapeutics here, and I want to go after the device guy here. And early when the GLP-1s come out, building on that, people say, oh, things like bariatric surgery are just dead in the water, right? And this is proving not to be the case. And maybe you can perhaps tell people a little bit about how that's changed and how EndoZip would fit in potentially.
Sure. Yeah, I think, first of all, here in the US especially, every other ad is a GLP-1 drug. And I think probably more people are microdosing than they are getting prescriptions. I mean, now you can just go online and pay whatever you pay, and you can get access to the drug, and then a primary care doctor can teach you even how to self-inject these things. There was a big wave, I'd say a few years ago, where the thought was GLP-1 drugs would really solve the obesity problem. But again, it gets back to who would be the responders and who wouldn't, and everybody was being put on these drugs. And then we saw over time compliance rates went down. I think there was a recent publication now that showed as much as 54% of people fall off the drug even in 12 weeks now. So in clinical practice, you see various reasons for that. When you'll ask clinicians, they'll say part of it, of course, is nausea. They can't. And now with the pill formulation, a lot more, I think patients are willing to try GLP-1s, but then that also comes with side effects. The tolerance levels can be quite different. Or in the US in particular, insurance coverage changes also, where the drug would become non-covered. But one thing is for sure, the GLP-1 craze has been quite impactful to the extent, like you just said, John, is that, bariatric surgery is a discipline now. They're concerned. There are recent publications that show as much as, 30 to 50% of volume reduction in bariatric surgical volume now, because patients are going on drug therapy as a first-line treatment. Lifestyle fails. They're going on drug therapy as a first-line treatment. Their BMI does reduce, and now they're not, they stop therapy, but they wouldn't necessarily be indicated for a major surgical intervention. So they're looking for other solutions. And going back on another drug isn't necessarily the first thing that they're looking to do. So, interestingly enough, when we look at endoscopic sleeve gastroplasty, which was developed many years ago, primarily by Apollo Endosurgery, and now Boston is driving that procedure forward, the number one feeder of patients into the minimally invasive procedural funnel are GLP-1 churn. They're patients that are coming off drug therapy, that are experiencing rapid weight regain, and they're looking for a solution, and cutting out 2/3 of their stomach isn't necessarily the first thing that they're thinking of. Although I will say bariatric surgery still provides probably the best total body weight loss and does have positive metabolic impact, but there are a lot of side effects with that drug. Now the issue then becomes like everything else. So now you maybe have a minimally invasive procedure, but access is quite limited because the procedure is quite complex to perform. So unless you're a very skilled interventional endoscopist, who by the way are not necessarily treating obese patients, they're getting referred in by physicians that are treating obese patients, they wouldn't be able to perform the procedure. So you kind of see this growing bolus of patients that are quite frustrated because they were on drugs, they stopped drug therapy, they're looking for something other than surgery, and the number of physicians that can offer them something else is quite limited. Yeah.
So it's interesting to me if you put that together with the phenotypes that you were describing, right? Is there a world where the phenotypes could either help decide where this would be more appropriate, right? And could it be that EndoZip fits into that patient journey either as a continuation, as an option for physicians versus more traditional testing and putting them on an amylin or whatever we talk about, or even a rescue situation as well, right? But it may, I don't know, it might only apply to a certain phenotype, right? And that's...
Well, I need to apologize to Lloyd that I did not put our data that we have on bariatric endoscopy, bariatric surgery, and I did not show the data on lifestyle interventions either. So the beauty about looking at biological traits that are independent of building a biomarker to respond to X, right? So if you build a biomarker that responds to X medication, let's say a GLP-1 or semaglutide, you're going to stuck with that medication and that biomarker forever. But when you build biological traits that are common among us, and some of us may be more presented than in others, you can apply different levels of care. So we also have data, and that paper came early this year on obesity surgery, that patients who have the low CTS GRS, the ones who respond to GLP-1s, also respond to the endoscopic sleeve gastroplasty done by the Apollo method. We'd love to see what happened with Nitinotes, but I would say it's exactly the same because biology is the same. And we also have data to show that those patients actually respond well to the Roux-en-Y gastric bypass. So it's very interesting, is the same biological biomarkers. You can see whether you are based on what you want to do and how much weight you need to lose. So, so it's a great tool. 21% sustained in 24 months with one procedure that lasts 45 minutes, and it still costs a little bit, but that's another issue. Yeah.
Maybe just one quick maybe call to action or just observation. So there are some data out there. There's not a lot, but if you look at some of the published literature, and if you look at the state of fibrosis in adipose tissue, there's actually quite some powerful trajectory determinants if you look at how much fibrosis, how much extracellular matrix is in the adipose tissue when you go in and perform a surgery. Mm-hmm. And you can actually see that the patients with more fibroinflammation in adipose tissue tend to do a little bit worse than others. So even in the context of a med device, you know, I think there's still an opportunity to learn more about the disease, right? That's my call to action is we should always look for more biopsies, more blood, you know, and share those data, because that's another big problem is that there's not enough data federation in our community to share all these data sets and samples. And we need to do that because right now there's a lot of silos, which I think is slowing us down a little bit in terms of data and sample sharing.
Mm-hmm. Sorry, maybe just one other point if I could mention. So the other thing I think we have to think of is we had a tendency to think of either or scenarios. You get drugs or you get intervention or you get surgery. And now we're seeing more and more in clinical practice concomitant therapies. So I just mentioned cite one publication, which was in Obesity Pillars in 2024, where they looked at, I think around slightly more than 1,500 patients who were on GLP-1 and or had concomitant ESG intervention. Mm-hmm. And they showed that those patients that had concomitant therapy had more durable weight loss, more positive metabolic outcome. I think their total body weight loss percentage reduction approached 30%, which is equivalent to surgery. So we see more and more concomitant therapy. Of course, payment, market access is a question. You know, reimbursement needs to be put in place for these things so that people aren't paying for them out of pocket. But I think there's a world where different therapies need to exist depending on the etiology of the person's obesity. So.
All right, so we have a few minutes left. Maybe just one quick question to you, Laurent, is do you have any hypotheses on what the most relevant stratifications might be, you know, as you're thinking about it?
It's a great question, and I want to go back to Andres' talk. So I'm especially driven by the low responders and the hyper responders, and what makes these bookends, you know, very informative in terms of biology. So that's my sort of preamble to your question, which is a fantastic theme. And the answer is we need in our space quick wins. And just speaking from the perspective of a small biotech, you don't get to try many times your first-in-class drug. You basically have one shot at showing that it's going to work, and so you need to really be sharp on who are the patients that are most likely to respond. So it's okay to then take a little cut of the big pie to show rapid response in a patient population that has perhaps a lot of your marker of interest. But then over time, as you go through the typical 1A, 1B, 2, and 3, and so on, you sort of look retrospectively at sort of some sub-studies to see, well, can I loosen a little bit my inclusion-exclusion criteria? So that's one perspective. In other words, it's okay initially, at least in our world, to start very precise, but that carries all sorts of challenges with the label. And if you need to do a companion diagnostic, then that's not difficult necessarily, but it's another consideration. So for us, I think oncology and other, even CNS, frankly, the space of neuro has actually been moving faster, I think, than our space, because you can use A beta imaging, right, for decision. And that's surprising, right? Because I would have thought that we would be a little bit more behind oncology, but not behind neuro, considering sort of, the dynamics. But that's kind of the view of stratification is okay to start narrow, but try to make have the biggest impact across as many patients as possible over time.
Yeah. Thank you on that. I'm gonna turn to questions. So please put your hand up. Anyone's got a question? Yes, sir. You've not got a microphone, but you've got a question. That's it.
It's a question about something that came up in a previous discussion where somebody was talking about how in the case of secondary prevention, they had to wait until they had a primary event before they could get their payer to reimburse them for treatment to prevent the secondary event. And I was wondering what the panel thought about the idea of finding a biomarker that is sufficiently selective and predictive to run a primary prevention study. Is that a goal that is too high, or do you think that might be achievable?
Andrea, do you have a view on that?
May I just one word to that? I think when looking at the literature at the moment, what we did or what is done in diabetes, right? You at least monitor what was the time point of diagnosis and how many years that a patient has already diabetes. I have not seen in any obesity trial yet whether there was a question for how many years are you at this BMI off and how many weight cycles did you already go? Because it could be the underlying sort of difference between responders and non-responders in our days. We don't even characterize the patients that we treat nowadays to these simple sort of assessment of the trajectory of the disease in the first place, to your point of primary, secondary prevention, if you want. Yeah? And I think this would be a crucial basic parameter to assess, for instance.
Jay, that's a little bit of a holy grail for everyone in the cardiometabolic space in obesity. When I've been asked this question, I come to two things that I think are important is identify who will be your super responders for your drug, so you eliminate all those people who might not benefit from it. But you also need to identify who are the highest people at risk of having an event in a short enough period, as Robert was saying. You cannot follow them for 15 years. You need to have an event in 3 years, otherwise it's unaffordable, the trial. But you need to have, because the large is so huge, the trial will be so huge, you need to have super responders within the trial and people who are at very high risk of having that event within the next 3 years, so that have not had an event. So maybe you just do that with a coronary CT and you see people with high disease or high risk for disease, so they're about to have a heart attack, and then you put them on a preventive drug. I hope that Lilly or Novo take that sooner or later and we really show preventive, or BI. So sorry for leaving you out, and really take that on and show primary prevention.
Hi, I would like to hear your comments. You brought up one of the statistics of discontinuation rates. We know that greater than 50% of patients are discontinue within a year. Greater than 80%, and these are non-diabetic patients, discontinue within 2 years. You know, in any other industry, losing 80% of your customer base would be disastrous. So I'm wondering about your thoughts. How does the pharmaceutical industry plan to address a pretty significant limitation and problem with current drugs?
I'm not from a pharma company, but I would say the answer really is precision medicine. I think we need to find the patients that will respond to certain treatments, and then the ones that are not appropriate for that treatment should be put on another treatment. So it's really consistent with the theme of this panel is we have to figure out in more detail who will respond, who might have side effects, and who is appropriate for which treatment.
Yeah. I mean, what we see... Please,
yeah, maybe if I may. So to that question, I think despite the current treatments available, I think we are not yet there to really treat obesity as a disease, number one. And number two, the solution to a continued treatment, in my perspective, is to accept excess adipose tissue mass as a risk factor, like we do for blood pressure, LDL cholesterol, and HbA1c. However, the SELECT trial that was conducted, a landmark trial, was showing what was to be expected, that the benefit was not related to the weight loss, or only partially, I would say. So that means at the end, what we need to establish in obesity is a clear treatment goal in the first place, and something that not only the patient, but also the payers or the healthcare system acknowledges as a true benefit. And then I think you have a way to also tackle the question of treatment persistence. Yeah.
We spoke very little about discontinuation. I think it's a big issue. Let's move out payers and not coverage outside for a sec, because I think we know that's the biggest driver right now. But then we have lack of efficacy or side effects. So maybe with predicting the best patients, we can avoid the lack of efficacy and patients will see more weight. But it's still, even when we predict better responders, patients are going to plateau. So Marija was talking about educating the patients and the practitioners, changing that expectation, right? The drug's not stopping working, you start losing weight, you already lost 15 or 20%. You're just plateauing because your body has metabolic adaptation. So education is key, but also predicting side effects. We talk about a lot of predicting outcomes. We also need to predict side effects. We shared last year our National Beating Digestive Diseases Week, the first model, GLP-1 induced nausea that we can predict based on genetics. I call it the gene test for GLP-1 induced nausea, gene. So with the gene test, we might be able to know who is at high risk of nausea and vomiting and severe nausea and vomiting. So maybe those patients, we still give them the med, but we are just more proactive and saying, and here's your prescriptions for Sofran, right? Because we don't want you to get sick and end up in the emergency room vomiting. But that is, I think, a great way we can think about discontinuation, and we need to work on that on the clinics.
Sorry, just one other quick point. I think I started off by saying also the stigma around obesity. I just wonder how many patients, they say, I want to lose 30 pounds, they get to their weight, and I'm not even sure they acknowledge necessarily the own state of their disease. I mean, patients that have hypertension, they start with the drugs, they realize they're going to be on drugs forever, they take them, the compliance rates are probably better, but there's not necessarily a stigma around hypertension. But obesity, even in the mind of people living with obesity, I think they really, they might not internalize it either. They reach a target goal weight, they're fine, and then they go back to these sort of old habits. So I think putting the patient in the center of their treatment and helping them come to realize that this could be a lifelong disease for them is very important.
Yeah, so thank you on that note. And I think the other thing I'll just add, and then we're going to wrap it up, is that we're still at the beginning of the evolution here. Many of the companies here are working on different aspects of the needs of patients. And as I say as a consultant, the segmentation of the patients, or the personalization of the patients, and the precision medicine are all part of it. But I want to thank the panel for coming up here and having a good conversation. I only got through about 2/3 of the questions, so please collar us afterwards, and we'll happily answer more questions that are there. Last word, over to you, Andre.
No, thanks again to Laurent and Sachs for the invitation. I'm delighted to be here with the panel, and thanks, John, for leading this.
you.